Hi everyone, Hospice Nurse Julie here. So today's going to be a longer video where I fully discuss what a hospice admission can look like. So they are going to differ depending on agency, but in general, this is what I do during my hospice admissions with patients. So in my company, we do the BOE or benefit of election, meaning we explain all of what hospice means and what you get, what you don't get, and then have patients sign. Now, some companies have the nurse do it, some companies have social workers do it, or a hospice liaison do it. So in my company, I do it. I'm the admission nurse. I'm there for almost 2 hours with the family usually because I do a lot of talking and I answer a lot of their questions. So what I do is I come in, I introduce myself, I have the patient and the family all sit together. Unless the patient is fully unresponsive or confused or is too tired, sometimes I won't have the patient there if they choose that. I usually start off by saying, who I am and how long I've been a nurse, and that I was an ICU nurse prior to being a hospice nurse, just so they know that I've had some experience. And then I also say, I've looked through your chart. Some agencies don't have the privilege, the ability to do that, but our agency, we do. So I've looked through their chart. I know what's been going on, but I just need to fill in a few blanks. And then I'll say, the first thing I like to talk about is like what hospice is all about to make sure we're all on the same page. So then I say, to me, hospice is about living. It's not about dying, like many people think. However, you do have to technically have a diagnosis of less than 6 months to live. And hospice will help you manage symptoms, manage your disease so you can live out the rest of your life, however long that is. 6 months, a year, 2 weeks. We don't know. Everyone has an end of life journey, and we help you manage yours and help you understand yours while you're going through it. You do get a bunch of benefits over here from the hospice company, and I'll explain those in a second. But you will lose some things over here if you choose to sign up for hospice. So the things you will lose are the ability to treat your disease, radiation, chemo. If you have heart disease, you'll no longer be able to see your cardiologist. So you lose some things. You're not supposed to go back to the ER. You're not supposed to really use the hospital. You're supposed to use the hospice company. And a lot of people are surprised by that. Some aren't, some are. Now, I will say you can sign up for hospice and then in a week decide, I don't want to do hospice anymore. And you can just come off hospice. No one's making you stay on hospice. You can just come off. So you do have that ability to do that. You're not stuck once you signed on. So you also can have, let's say you're on hospice for metastatic lung cancer. You can no longer see your oncologist, your radiologist, people that are seeing you for your lung cancer, but you could still see your podiatrist for your foot, or you could still see your cardiologist for your AFib. So you still can do those things. However, I will say it'll probably be more convenient to go through the hospice company, but you don't have to. So once I acknowledge all of those things, the family will sometimes have questions, sometimes not. Then I talk about their particular disease. So I ask if it's okay and if they are interested in kind of understanding the end of life process, how the body shuts down, what to expect. And most people are. So that's when I usually go into what I'm seeing with the person specifically. So I'll often say, you'll probably be noticing that you sleep a lot. And mostly the patient and the family's like, yes, that's already happening. You probably notice that you don't have much of an appetite. You're not really hungry. Yes, that's been happening. And then depending on the different disease, they have liver disease, you might notice that you have a lot of swelling in your abdomen. That's ascites. We can drain that for you. Here's how we do this. Or if they've been having a lot of shortness of breath, how we can manage the shortness of breath, how we can manage the pain if they've been having any. And if they haven't been having symptoms like that, but they've just been really concerned about, well, he's not eating enough or he's not moving enough, that's when I get into why that's happening, which is our bodies are built to die. Our bodies biologically know that the end of life is near and will start sleeping all the time. Will start making you not hungry and thirsty. And from what I have seen, the more you listen to your body, the better you live and the more peaceful you die. And usually that's reassuring to the family and to the patient. And that helps the family kind of mold together for one common goal of comfort versus trying kind of fighting, like, take your medicine, I don't want to, eat, I don't want to, back and forth. So it kind of gets everyone on the same page. Usually it doesn't always work out like that, but sometimes me saying that, the patient will be like, I told you guys I don't have to eat if I don't want to, and the family's like, well, we're just trying to take care of you. But once they hear that really taking care of the person is by letting them do what they want, I always say the patient is now the boss. And even if that patient can't say what they need and want, their body usually does. So if it's an Alzheimer's patient who hasn't spoken for 6 months, but they won't open their mouth to be fed, that's it right there. You do not force that. You can always try, you can always offer, but if they're not doing it, let their body be the guide. Let their body be the guide. At this point, I usually will start asking, are there any questions? Sometimes the families will say, well, do you know how much time? Or sometimes the patient will say, do you know how much time I have? And the thing I say to that is sometimes when someone comes on, I'd say late, meaning they are closer to death, they're pretty close to death, like a few weeks, it's pretty obvious to a hospice nurse usually, because they're bed bound, they're sleeping 18 hours a day, they're not eating and drinking, and they haven't been for like 2 weeks. That tells me they're closer to death. When they're just coming on and they're still walking and talking and going to the bathroom by themselves and still eating a couple meals a day, they're likely further away from death. Even though 6 months isn't a long time, but it's still further. So the further you are away from death, the grayer the area is. So we have to give you like a range. I'd always go, you're probably in the 6 months range if they're further away. If they're not so far away, by showing evidence of functional decline, mental decline, food and water intake, and they seem a little closer and they're seeing dead relatives and stuff, I would say you're probably in the month to a couple months range. So you always give a range. Some hospice nurses will not do that, but I feel comfortable doing that as long as I give a range. And usually the closer to death you are, the easier it is to know how close someone is, if that makes sense. When someone's actively dying, it's very easy to tell as a hospice nurse, and you would say, I feel like they're a few days away. So that's how I'd answer that if someone says, how close do you think I am? That's the verbiage I usually use. Then I go into medications. If they don't have any more questions, I'll say, let's talk medications. And I'll have them bring out all the medications they take. All the ones they take on a daily basis, as an as-needed basis, and then any kind of like vitamin or kind of drink or whatever they take. I bring it all out. And I talk with them and the doctor, of course. So the doctor's usually not there, but they're on the phone, and me and the doctor are going back and forth between what's going on. Because I have to do this all with doctor's permission. I can't just do shit because I'm a nurse. So the doctor is really involved. I'm the eyes and ears for the doctor. So we're reviewing the medications. If the patient says, I don't want to take any of these anymore, the patient's a boss. They don't have to. But there's some medications that I may persuade someone to take, or try to anyway, because I know they'll manage symptoms well. So if someone's having seizures, but they're like, I don't want to take the anti-seizure medicine, I'll respect what they want, but I'll also say, this is helping you not have seizures. Or if someone has lung disease and they've been on long-term steroids and they say, I don't want to take that anymore, I may try to push them to take it because I know steroids will help them feel less short of breath, right? So it just depends. But ultimately, it's up to the person. And if the person cannot swallow pills, then we really back off. There are some medicines we can use that we can make into liquids, but in general, if someone's not swallowing, we just back off totally and use comfort medications only, which are usually sublingual in the gums or suppository, which I order for everybody. So all of my patients get the comfort kit, which is 8 medications we give to almost every patient. They're not always used. I have a bunch of videos about the comfort pack or comfort medications, and some hospice companies don't give it to everybody. Some hospice companies do. We like to give it because just in case, if someone calls at 2 a.m. for agitation, but there's no medication there for agitation, what are we gonna do? So we like to have it there just in case. And a lot of the medications in the comfort box, if you haven't watched my videos, are things for pain, shortness of breath, agitation, nausea and vomiting, constipation, and fevers. And then terminal secretions. There's one for terminal secretions too. I usually will go over what it looks like to be actively dying, like the normal signs, the normal decline when someone's dying, just so people don't freak out if they start seeing it. I can talk to them about visioning, just in case their loved ones start seeing dead relatives. I'll talk about the surge or the rally, just in case they see that, which is when someone kind of gets a burst of energy right before they die. Ultimately, I'm kind of reading the family too to see, like, are they getting overwhelmed? Is this too much? Or are they handling this well and like the information? Everyone's different. So not every admission am I like rattling off a bunch of facts, because sometimes it's just too much. And this is just the first visit, right? So you gotta read the room a bit as a hospice nurse. Then of course I do my full head to toe assessment on the patient, where I do, a nursing full head to toe assessment, check for wounds, check their lungs, blood pressure. We measure their arm, which we do every month to see if they're losing muscle mass and weight. Just a full head to toe. I guess if a nurse is listening, you know what I mean. So you just do a full head to toe assessment, make sure everything looks okay. It may not look okay too, but that could be their baseline. So as long as they feel comfortable. So a lot of times if someone has crazy vitals, we don't necessarily do something about that on hospice. We go by how they look. If someone's oxygen's low, but they feel okay and they're not short of breath, we're okay with that. If someone's oxygen is not low, but they feel short of breath, we're going to treat that. We're not going to let them feel short of breath just because they have a normal oxygen. So we go a lot by how they look and how they feel and what they're telling us. Wounds, we do treat wounds. We do treat infections. We don't have to. Some people say no. Some people actually say do not treat a UTI if I have one. But yeah, we do treat infections. We do treat wounds. Our goal for wounds is not for healing, just because it's almost impossible to heal a wound on a dying body because the skin is an organ and the organ's shutting down. But we do try to prevent infection. So that's our main focus with wounds on hospice patients. We order equipment, so we can order a hospital bed, a bedside commode, a shower chair, wheelchair, walker, a Hoyer lift. Those are the things I think of offhand. Those will be delivered by a company in a day or two. We can order supplies like bed pads, briefs, gloves, wound care supplies if they need it. We can do central lines, dressing changes if they have a central line. We usually don't mess with central lines on hospice, but sometimes patients have them. We can order, I said wounds. We can order drains. So like some people have, we drain ascites because they have a pigtail in their abdomen, to drain ascites from liver failure or any kind of like liver cancer. We can order those drains. So we can order a lot of things. We also can supply medication and refill medication and get the medication delivered. So no more running to the pharmacy, which is really nice. The pharmacy is the worst. No offense, pharmacists. And then after all of that is done, most hospice companies leave you a folder with the 24-hour number, because, so let's tell you what we do, what Medicare says we're allowed to provide. Okay, so what we're allowed to provide on hospice, and this is Medicare Standards. So Medicare Standards say this: you have to have a nurse come at least once a week. So the lowest is once a week. They can come up to every day if there's issues, right? You have a home health aide that can come 2-3 times a week to give you a bath or a shower or a bed bath. You have a doctor that will visit. Every hospice is different on this. I don't know the exact regulations, but doctors don't have to be there very often. And then you have a social worker and a chaplain. The chaplain is not meant to be a religious person. They will go with whatever religion you are working with or any kind of spirituality that you're working with. And the social worker is there for emotional support, psychosocial support, financial issues, kind of to help you find programs you might qualify for, things like that. So use your hospice team. They also provide you with a number that's 24 hours a day. So you can call that number at 2 a.m. if your loved one on hospice is having pain, and an on-call nurse can go to your house to fix the problem that night. So utilize that if you have it. You can also switch hospice companies if you're not happy with the hospice company that you have currently. So please know your rights and know that you can do that. There is a thing called continuous care nursing. I can get a little bit of a soapbox on this because some companies make this, give other companies a bad rap. Okay, so every hospice company in the United States is governed by Medicare. Everyone. There's no private hospice company. So whether you're nonprofit or whether you're for-profit, you're still governed by Medicare. Now, for some reason, I don't know how they do it. I think they'll probably eventually get shut down because they're technically doing Medicare fraud, but there'll be some companies that will provide continuous care nursing, which is a 24-hour nurse. So every 8 hours they switch out nurses to be in the home to manage some kind of symptom. So that's the point of continuous care. Continuous care can happen. Every agency should be able to provide that for families if they need it. However, there are requirements to be able to provide it. And the requirement is some kind of unmanaged symptom, unmanaged pain, unmanaged agitation, unmanaged shortness of breath, meaning we can prove to Medicare that a nurse has been there in the past couple days frequently and they can't manage their pain on their own. So they need a nurse there 24 hours a day to get that symptom under control. So a hospice company legally should have that system built into their hospice company. Now, once, say the nurse comes in, the continuous care nurse comes in, and they're there for 2 days, and then after 2 days, the pain is managed. That hospice company legally needs to take that continuous care nurse out now because the symptom is managed. That's what Medicare says. But there are some... I have a tickle. And I can't pause it because then I can't restart this whole thing. Because I don't know what I'm doing. You guys are just going to deal with this with me, okay? This is why I need an editor. I'm not going to stop. I'm 18 minutes in. Got it. One day I'll get an editor, you guys. Okay, I've been having this tickle. So, some hospice companies will just let the continuous care nurse stay there. Or they'll use the continuous care nurse for things like caregiving needs. Like the family doesn't have any caregivers, so they let the continuous care nurse stay there so this person can be changed. Now, don't get me wrong. I wish we could do that. So many families need this. However, legally, we're not allowed to provide that. So the companies that do provide that, although they seem like they're doing a good job, here we go again. Although they seem like the company's doing a good job and a good thing, which I think they kind of are, they're still committing Medicare fraud and giving all of the rest of the companies who aren't committing Medicare fraud, they make them look bad. Like, well, this company did this for my grandpa. Why won't you provide this? Well, we legally can't, you know? So I don't know how companies do that without getting in trouble. I'm sure they probably eventually do get in trouble. And it's stuff like that that will shut down a hospice company. So I'm surprised any hospice company would do that, because hospices are very, very much audited. We are audited hardcore by Medicare. So a hospice company cannot really do stuff like that, like provide continuous care when it's not actually needed very much, without getting shut down by the government. So I'm saying all of this so people who are out there who have run into that know why that happens and why it doesn't happen with some other hospice companies. So in a nutshell, that's a hospice admission. So I only did it in 20 minutes because I'm not actually going through medications. I'm not actually checking out somebody head to toe, doing a full assessment. But in general, those are the things that will go on in an assessment or in an admission. And then I give them the folder. I tell them who they call. And then the nurse who's going to be their case manager will follow up later that week or next week. And then if they need anything, to always give us a call. So I hope that helped you guys. Thank you for bearing with me with my cough. And I'll post more videos like this soon. Love ya.